Dr. Baliga here. This podcast belongs to a set of 10 podcasts on the topic of geriatrics. It's from an outstanding chapter on geriatrics in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It covers important topics including functional decline and frailty, cognitive impairment and dementia, evaluation of cognitively impaired elderly driver, depression in late life, hearing impairment, vision impairment, urinary incontinence, undernutrition, pharmacotherapeutic considerations in the elderly, including pharmacokinetics and pharmacodynamics, elder abuse and neglect, goals of care and advanced directives, and prognostication. After listening to these 10 podcasts, you should have a solid foundation in geriatrics and should help you provide better care to your senior citizen patients. This chapter is authored by Dr. Jeanette Ross, MD, who's professor at the University of Texas Health Science Center at San Antonio. She is the Associate Program Director for Geriatric Fellowship and Director of Didactic Activities for Palliative Care and Geriatric Fellows. Her academic interests include integrating geriatric palliative care content into educational programs at the undergraduate and the graduate medical educational levels. The senior author is Dr. Widera, MD, who is Professor of Clinical Medicine in the Division of Geriatrics at the University of California, San Francisco, UCSF. He is also the Associate Program Director for Geriatrics. His main goal is to improve the care provided to elderly patients with severe chronic and/or terminal conditions through program development and educational interventions. Multiple choice question. A 68-year-old man is brought to your clinic by his wife because of problems with falling frequently, memory loss, and vivid visual hallucinations. On physical exam, you note that the patient has a shuffling gait. Based on his history, which of the following is the most likely diagnosis? A. Alzheimer's disease. B. Dementia with Lewy bodies. C. Frontotemporal dementia. D. Normal pressure hydrocephalus. And E. Vascular dementia or multi-infarct dementia. And the answer is B. Or dementia with Lewy bodies. The clinical picture described in the case of Parkinson's features with frequent falls and visual hallucinations are typical of patients with dementia with Lewy bodies. Alzheimer's disease is characterized by a gradually progressive cognitive decline, characterized by early memory loss and executive dysfunction. Frontotemporal dementia usually presents with language disturbance and personality changes and starts in the 50s and 60s. Normal pressure hydrocephalus typically presents with the wet, wobbly, and wacky triad in reference to symptoms of urinary incontinence, gait disturbance, usually apraxic magnetic gait, and memory loss. Vascular dementia typically presents with stepwise progression of cognitive decline. Common types of dementia. Alzheimer's disease is the most prevalent type of dementia, accounting for 60 to 80% of all dementia cases. Alzheimer's dementia has a gradual onset and evolves over several years. The hallmark of Alzheimer's dementia is a progressive impairment in memory. In the early stage, Alzheimer's dementia will have difficulty with recent memory. Over time, individuals with Alzheimer's dementia have difficulty with all cognitive domains and require increased need for assistance with instrumental and basic activities of daily living. In the advanced Alzheimer's dementia stages, patients will display behavior changes and difficulty speaking, swallowing, and walking. Vascular dementia is the second most common type of dementia. It results from vascular disease changes within the brain that lead to cognitive impairment. The cognitive changes in vascular dementia can remain mild for a substantial period of time. It is important to recognize vascular dementia in the early stages because proper medical management of cerebrovascular disease factors, particularly diabetes, high blood pressure, and smoking, can reduce the risk of developing cognitive impairment. Vascular dementia commonly progresses slowly over time, although it can also progress in a stepwise fashion in which the initial cognitive deficits plateau for a period of time, followed by the sudden onset of additional cognitive deficits. Lewy body dementia is a degenerative brain disease associated with abnormal alpha synuclein clumps or Lewy bodies. Patients with Lewy body dementia experience a progressive cognitive decline. Common symptoms include visual hallucinations, commonly of children or little people, problems with movement or Parkinsonism features, and fluctuating attention. Patients with Lewy body dementia have autonomic dysfunction and may present with falls and syncope. Lewy body dementia patients are particularly sensitive to neuroleptic medications and if exposed to them can become catatonic, lose cognitive function, or develop more muscle rigidity. Frontotemporal dementia is a dementia with a typical age of onset in the 50s and 60s, which is about a decade earlier than those with Alzheimer's dementia. It's a disorder in which there is focal atrophy of the frontal and temporal lobes. Dysfunction of behavior and language are the primary manifestations of frontotemporal dementia. Changes in personality and behavior exhibited by frontotemporal dementia patients lead them to have a lack of concern for social norms or other people and poor insight. Frontotemporal dementia may be misdiagnosed as a psychiatric disorder because of the wide range of symptoms and its gradual onset. Cognitive evaluation of dementia. During the early stages of dementia, the patients may not realize their cognitive problems and react with denial. Typically, it is a family member who notices deficits and brings the patient to a healthcare provider. It is important to perform objective cognitive testing because even in more advanced stages, patients with dementia may retain social grace and skill that can mislead both the families and clinicians. There are several validated screening exams, including the Mini Mental State Exam, the St. Louis, Missouri Mental State Exam, the Montreal Cognitive Assessment, the Executive Clock Drawing Task, and the Mini-COG. The Mini-COG is a brief dementia screening tool. It includes 3 components. 1. Instruct the patient to listen carefully. 2. And remember 3 unrelated words. And then repeat the words. 2. Drawing the clock. Instruct the patient to draw the face of the clock with the hands of the clock to read a specific time. The instructions may be repeated, but no additional instructions should be given. Give the patient as much time needed to complete the task. The third component is to ask the patient to repeat the 3 previously presented words. Scoring. Give 1 point for each recalled words after the clock draw test distractor. A score of 0 is a positive screen for dementia. A score of 1 to 2 with an abnormal clock is a positive screen. A score of 1 to 2 with a normal clock draw test is a negative screen, and a score of 3 is a negative screen. This podcast is derived from an outstanding chapter on geriatrics in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It's authored by Dr. Jeanette Ross, MD, professor at the University of Texas Health Science Center at San Antonio. She is also the Associate Program Director for Geriatric Fellowship. Her academic interests include integrating geriatric palliative care content into educational programs at the undergraduate and graduate medical education levels. Her main interests include advanced communication skills, goals of care, pain management, and management of falls in the elderly. Her clinical activities are based in the South Texas VA healthcare system, where she is a staff physician within the Geriatrics department and extended care services, and she is affiliated with the Geriatric Research, Education and Clinical Center. She works in the Geriatrics and Palliative Care Consultation Service and the Geriatrics Clinic. Dr. Eric Widera, MD, is Professor of Clinical Medicine in the Division of Geriatrics at UCSF, that is University of California, San Francisco. He is also the Associate Program Director for Geriatrics. His main goal is to improve the care provided to elderly patients with severe chronic and/or terminal conditions through program development and educational innovations. Dr. Widera accomplishes this through various leadership roles, including Director of the Hospice and Palliative Care Service at San Francisco VA Medical Center, and he is the Program Director for the Geriatric Fellowship at UCSF. He has been the recipient of numerous grants and awards, including a Geriatric Academic Center Award at the Hastings Center Kenneth Dixon Physician Award and the Hartford Foundation as a Center of Excellence Faculty Scholar Award.